Good evening. This is it's kind of ironic. As a pediatrician, alcohol, liver disease is a little bit strange for me, but that we follow the alcohol talks with the bar coming inside. That's number one. And giving a talk with the bar next to you, it's kind of difficult to compete, but we'll give it a try. So Dr. Saab and myself will be talking about Wilsondisease over the next 40 minutes or so. These are our disclosures. They've been pretty similar to those, at least from a pediatric perspective, that other pediatricians have actually. Just as a highlight, I do consult for Orphaland, one of the companies I believe that's sponsoring this session. So I'm a trivia guy, and so let me start off with a little trivia. And so copper was actually mined from the island of Cyprus way back in the Roman time and actually became known as the As Cyprium, which means the metal of Cyprus. That's where it was done. Eventually, the Cyprium evolved in popular Latin to cuprum, and that's where we get the Cu as the abbreviation, the atomic abbreviation for the copper. That was translated from cuprum in about the 1500s or so. I think 1560s was the first time that copper was used. So anyway, we go back to Cyprus to study Wilson disease and copper accumulation. So the educational objectives is noted here. We'll talk a little bit about actually the physiology and a little bit about the epidemiology and the pathogenesis of Wilson disease. I think importantly we'll identify some challenges, particularly Dr. Saab towards the latter part of the talk. And then he will also evaluate strategies to promote patient adherence, one of the most important and critical factors in treating any chronic disease such as Wilson. So Wilson disease was named after Kinnear Wilson, who is an American-born British neurologist. He described a group of individuals who had neurologic disease and also cirrhosis and gave it the name progressive lenticular degeneration. And it was, he wrote it as part of his gold award-winning PhD equivalent dissertation. It was eventually published in Brain in March of 1912. So Wilson disease goes back a long time. It affects about 1 in 30,000 individuals, or if you do a little different math, it's 3 per 1 million. And if you're doing a little more math, that translates to about 11 to 12,000 individuals that should have Wilson disease in the country, in the US. However, there are only about 2 to 3,000 persons who have been diagnosed with the disease in our country. So it's obviously that this disease is underdiagnosed, or more likely or more appropriately misdiagnosed with a variety of different liver neurological or psychiatric disorders because it affects multiple systems. So copper is an essential trace element. It is considered to be a critical cofactor in many enzymatic reactions in critical metabolic pathways. So therefore, if something is important, it's very strictly controlled by the body by 3 mechanisms. One is the gut, which is responsible for absorbing copper that we ingest. The liver, which removes excess copper and to be secreted by the biliary system, and I'll show you some pictures about this in a little bit. And also, obviously, it's used for metabolic pathways designed to lead to homeostasis. So this is a quick review of copper in the human. We eat about somewhere around 5 milligrams of copper, about half of which is bound to albumin and amino acids and gets to the liver through the portal vein. Some of that copper gets incorporated into ceruloplasmin, is secreted, and ceruloplasmin acts as the major copper carrying protein in blood, although there are other molecules that do that, as I've already mentioned, albumin, amino acids, and that's where it goes to other tissues. A very, very small amount of copper gets excreted through the kidneys. The majority of the copper gets excreted, in humans anyway, in the biliary tree. So that overall, of the 5 milligrams that you take in, 4 milligrams are excreted by these various processes. And so the utilization is about 1 milligram per day. And again, this is a very tightly controlled system. So this is in normal. Copper that's bound to either albumin or amino acids gets to the liver, and because it's very toxic, it needs to be bound to chaperones, including glutathione. There's an HAH1 molecule that also serves as a chaperone that then takes these copper molecules that are very toxic to various places where they need to go, like the superoxide dismutase, mitochondrial oxidase, superoxide C. Some of this excess copper gets stored in lysosomes in the blue up on the top of the cartoon of the liver cell. And some of this copper gets also incorporated. So the Wilsondisease protein does two things. The first thing it does is it incorporates copper into ceruloplasmin. The copperless ceruloplasmin, or apoceruloplasmin, becomes ceruloplasmin in this process, and this copper is excreted in the portal system bound to ceruloplasmin. So that's function number one. And function number two, and perhaps more important, is the fact that it directs the copper to the biliary system for excretion. So this is normal physiology. This is what happens within the liver cell, 40,000 feet look. So this is what happens in disease. The Wilsondisease protein, because of a number of mutations, now numbering over 700 of them, leads to aberrant Wilsondisease protein action. So two things happen. One is copper incorporation into ceruloplasmin is diminished, and that apoceruloplasmin, the one without copper, has a much, much lower half-life than the copper-containing ceruloplasmin, leading to the low ceruloplasmin, which is, as you'll see, typical of the diagnosing Wilson disease. And the other thing that happens is that there is now a diminished copper transport to the bile, leading to lack of excretion and accumulation in the liver cell, eventually going on into the liver cell and increasing the copper load, where then it's deposited in various liver tissues, notoriously the liver, as noticed in this picture, the cornea, the Deschmetz membrane in the eye, leading to the Kaiser-Fleischer rings, and the kidneys, leading to kidney disease, and the red blood cells, leading to the well-known Coombs negative hemolytic anemia that can be seen in patients with Wilson disease. But there are other places where copper can be deposited and happens much less likely, but the joints, heart, and pancreas can be also affected. So again, this is where the misdiagnosis comes, because these patients can come see not only the liver doc for liver disease, but they can come in through seeing various subspecialists. So although the topic of how copper causes toxicity or damage is beyond the realm of this talk, there are just three major mechanisms that they inhibit the function of cellular proteins. They can disrupt intracellular trafficking. But the most important part is that copper is a pro-oxidant molecule, so it leads to free radical formation and lipid peroxidation problems, membrane damage, and importantly, mitochondrial dysfunction. Again, this copper toxicity could be a talk in and of itself. So, as might be suggested, because of the accumulation or the deposit of copper happens in many different organs, you're going to have very many different clinical manifestations. From a liver standpoint, you see the whole gamut of liver disease, from asymptomatic elevated liver tests all the way through acute hepatitis, chronic hepatitis, cirrhosis, and acute liver failure as a presentation of the liver disease. I've already mentioned a little bit about Kaiser-Fleischer rings, and that's, again, deposition of copper in Deschmidt's membrane of the cornea. In the brain, copper can accumulate or deposit in the cortex, the thalamus, and substantia nigra, and so it leads to a whole variety of neuropsychiatric symptoms, including personality disorders, mood disorders, psychosis, cognitive impairment, drooling, difficulties talking, difficulties walking, difficulties writing. In the blood, I already mentioned the Coombs negative hemolytic anemia. In bones, it can lead to osteoporosis, osteoarthritis, joint pain. And in the other organs, I may have mentioned renal disease. And in the heart, you could get cardiomyopathy. You could get arrhythmias, very importantly, particularly supraventricular tachycardias. You could get tubular dysfunction, nephrolithiasis, aminoaciduria, hyperuricemia, and hyperphosphaturia. So again, a wide variety of symptoms can be related to the deposition or accumulation abnormally of copper in tissue. A little bit more about Kaiser-Fleischer rings. They're usually seen in this beautiful picture that you never see, this beautiful picture. But it's a brown deposition of, a brown discoloration of the peripheral aspect of the cornea. Typically, because of the blood supply to the cornea, the ring starts in the upper pole, then the inferior pole, and then finally the upper and the inferior poles unite, forming the circle. With treatment, the Kaiser-Fleischer rings goes away, and they go away in the same process. So you first lose on the sides, then on the bottom, and then on the top. So the way I've done it now, I just look at the top. If I don't see the top, it can't be there. I can't see it. And because it's oftentimes difficult to visualize and not impossible with your naked eye, a slit lamp is really necessary. So you need your ophthalmology colleagues for help in this one. There's also a CT scan that can be done to look for these things, but the slit lamp examination is usually the right way to do, the right way to go. Now, Kaiser-Fleischer rings are important because if you have neurologic disease, you'll probably see them in 90% of the time, significant amount. However, if you have no neurologic disease, as happens in young individuals, particularly children that I take care of, Kaiser-Fleischer rings are usually not seen. In excess of 60% of patients will not have a Kaiser-Fleischer rings. So if you see it, it's important. If you don't see it, it doesn't help you as much. The other rare eye finding is the sunflower cataracts. Where you see it's rare. It happens in about 1% of the patients with Wilsondisease. And it, as the picture depicts, is a central part of the cataract, and then there's like radiating ray-like structures from it. And if you have a very good imagination, this looks like a sunflower, hence the name. Interestingly, they have no impact on visual acuity, and as with Kaiser-Fleischer rings, they tend to go away with appropriate therapy. So the diagnosis of Wilson's disease, like the diagnosis of many other diseases, it would be ideal if we had one single test where if it's abnormal, you have the disease, and if it's normal, you don't have the disease. So that would be the gold standard. However, for Wilson disease, such test does not exist. And so we're left with having to look at a number of things in order to make the diagnosis, which makes it oftentimes a little difficult to reach at a confirmed diagnosis. And those things that you look at are clinical examination. I've already belabored Kaiser-Fleischer rings, evidence for liver disease, hepatosplenomegaly, evidence for neuropsychiatric disease, biochemical analyses, including liver tests, urinary copper, ceruloplasmin values, blood testing looking for the hemolytic anemia. Sometimes imaging can help in those with neuropsychiatric symptoms. Things such as MRI and CT scans can oftentimes help in the diagnosis, and obviously doing genetic testing, which is becoming more and more accessible and more prevalent these days, looking at mutations in the ATP7B, the gene that is associated with Wilson disease. So these are the tests that we routinely check, and some of the pitfalls of these tests. So serum ceruloplasmin is probably the number one thing we do to, quote, screen and, quote, for patients with Wilson disease. It typically is decreased by 50% of the normal values. For the pediatric audience, you have to remember that within the first year of life, ceruloplasmin levels are very, very low normally, so it doesn't help you in the very, very young. And then there is a period of time in early childhood through probably early teenage years where the ceruloplasmin normally is above the 20, quote unquote, the 20 milligrams per deciliter. In young children, it could be as high as 40 milligrams per deciliter. So you have to keep those in mind. Again, for my pediatric friends, keep that in mind when you see ceruloplasmin values in young individuals. Now, the problem with ceruloplasmin levels is an acute phase reactant. And so if you have hepatitis, that's inflammation. If that's inflammation, the ceruloplasmin levels are going to be elevated, perhaps even above the normal value. So you have to be careful. It could also be overestimated by the most commonly used assays for its determination, and that's using immunological assays. Estrogen therapy in pregnancy also upregulate the synthesis of ceruloplasmin, so you have to be careful when you are evaluating ceruloplasmin levels and have to ask about estrogen, birth control pills, and those kinds of things in the appropriate age setting. Low levels of ceruloplasmins are seen in any malabsorption syndrome. There's a rare syndrome of aceruloplasminemia where you make zero ceruloplasmin. And the other big confounder sometimes becomes the heterozygotes that also can have low ceruloplasmin level but not the disease. 24-hour urine copper levels are typically above 100 micrograms in 24 hours. Children usually have a lessened copper load, and so the normal, the typically seen in children is greater than 40 micrograms in 24 hours. It could be normal if you have an inadequate or inappropriate collection, and that's very important to assess or ask every time you check one of these urinary copper. I usually ask the person, either the child or an adult. I see adults with Wilson disease, how they did the collection and how good they were, and oftentimes they're pretty good about saying, this one didn't work very well, and you have to repeat it. It could be increased in hepatocellular necrosis, and that's why in the acute liver failure setting, the 24-hour urine copper tends to be much less useful. It could be also seen be elevated with other cholestatic syndromes, PBC, PSC, and others, and also due to contamination. Now, contamination is usually an old problem. You had these recipients or these collection, glass collection containers that had copper in them. You had to do hydrochloro HCl washouts, etc. That's not a problem anymore. Most labs use copper-free containers. The serum-free copper and free is in quotation because it's really not free. It's the bioavailable copper or the non-ceruloplasmin bound copper. It's typically high in patients with liver disease, with Wilson disease, typically is greater than 100 micrograms. But again, if you have ceruloplasmin levels that are overestimated, that value might be high if you do the estimate. And there are, at the moment, it's very difficult to get an accurate direct assay, although there is one being developed and it's available, a direct non-ceruloplasmin copper assay. It goes through Chicago. If you want more information, we can talk about that later. Hepatic copper is usually greater than 250 micrograms. However, that also, even though it would seem to be the gold standard for Wilson disease, if you have cirrhosis or advanced fibrosis, you have spotty areas where copper tends to be more accumulated, and those are in the regenerating nodules or in the cirrhotic nodules. And so if you biopsy an area that has cirrhotic nodules, well, then you're going to get your answer. But if you happen to biopsy areas that may not be as cirrhotic or as fibrotic, then your copper levels might be, in the liver, might be normal, at least lower than they should be. Falsely elevated hepatic copper levels occur in any cholestatic syndrome, as well as the KF rings, as I've already mentioned, and the increased urinary copper. And so, again, those are the drawbacks or the challenges with using all these number of clinicals. So it usually takes a composite, and under the supervision or direction of the late Peter Ferenczi, back in 2003, he joined a group, put a group together to look at how we could improve on diagnosing Wilson disease, and came up with this Leipzig score, named after the city where the meeting was held, where you look at all these clinical parameters and you assign a numerical value to them, whether they're there or not, or mild or severe, and then you come up with a number. And so if the number is less than 2, Wilson is very unlikely. If the number score is 3, it's possible, in quote, you need more testing. And if it's 4 or greater, that suggests that the patient is diagnosis established. And this has been very useful, not only in the clinical setting, but also in the research setting, to ascertain that patients who get on these trials, various trials, do in fact have confirmed Wilson disease. There are a number of emerging tests, and again, I have little time to go over, but there's a relative exchangeable copper that's the French group in particular has pioneered. Now it's also used lots in Spain, so it's a European thing. There's a speciation assay, and that's the one that I was talking about that's available in the US. Where you directly measure the non-ceruloplasmin bound copper. It's been used very effectively in clinical trials, and hopefully we'll be able to use it in the clinic to diagnose our patients within a short period of time. There's also a ATP7B peptide analysis that actually measures protein, the ATP7 protein that's being developed by Si-Hoon Han in Seattle, pediatric geneticist who's pretty much spent his life trying to get Wilson to be diagnosed, to have screening tests, neonatal screening tests for Wilson disease. And now there is a program in Washington. I think that it's like 30,000 individuals that have been tested. So we look forward to those results and see how good this ATP7B peptide analysis is. So now I'll pass it over to my colleague.
A new friend.
A new friend. We actually find out we're from the same country.
A similar background. That's crazy. So, like cousins.
Third remove.
Third remove. Well, thank everybody for coming today, and thank the organizers for letting me speak on Wilson disease. I'm flipping the table a little bit and talk about treatment of Wilson disease and focusing on overcoming barriers. So the treatment of Wilson disease could be put into 2 buckets. Primary, diet, and the foods that are rich in copper, shellfish and nuts and chocolate, all the stuff that he's good, huh? And in pharmacotherapy, talk about chelation of copper, removing copper that's already inside of you. Another pharmacotherapy is blocking absorption. We're going to talk about very shortly. And then the ultimate therapy that's done not very commonly for Wilson's disease is liver transplantation, where you place a whole liver. Generally, people that come to us for liver transplantation are in acute liver failure, generally in their late teens, early 20s. And if you look at their graft that's taken out, they actually have underlying cirrhosis. And treatment also revolves around treating neurological symptoms, psychiatric problems. And it's interesting that when kids present, they present with neurological problems. And when adults come to us, they usually have some kind of liver abnormality. And I'm going to highlight a case at the next presentation. So the treatments, chelating agents, deep penicillamine, trientine. And then medicines that block copper absorption is zinc. Now, who here has prescribed deep penicillamine? You have? Have you used penicillamine? What do you use in your practice? Trientine. Sharon and I take care of a number of patients, and I don't think we ever used trientine. It's a deep penicillamine. We've always used trientine, but why did you use deep penicillamine? Insurance issues. You talk to him afterwards. He'll get you. In fact, when I was a fellow at the VA hospital, I met one of the first people treated in the VA with deep penicillamine. Deep penicillamine scares me, I'll be honest. It's got a lot of baggage: fever, rashes, proteinuria, leukopenia, anemia. It's a lot of side effects. Whereas trientine, at least, is much better tolerated. And in zinc, we worry about the GI side effects. So here's an algorithm that Neil Corey, as he's part of the very famous for metabolic fatty liver disease, and he also, before fatty liver, had a life in Wilson's disease. And he talks about, asymptomatic patients, maybe trientine, zinc, the penicillamine, but first sign is zinc, people who are asymptomatic. In people symptomatic, you got to think about chelating agents. I think it's debatable what's first line, second line. I think for us it'd be trying to be first line therapy. Deep penicillin, we don't use very much at all. This is from the paper published in hepatology a couple years ago. And what I like about this paper is this particular table, because not only does it give you signposts in terms of efficacy, what urine values to shoot for when you put someone on deep penicillamine, trientine, or zinc. What's a 24-hour urine collection should look like. But what I like about this that I've not seen in prior publications, let me know if I'm wrong, is when do you know when you go too far? When do you know when you're over-treating someone with zinc, trientine, and penicillamine? That's what I like about this. Also highlights the side effects, what to look out for. For instance, trientine, if you over-treat someone, you might see anemia, you might see leukopenia. And also highlights treatment failures as well. When do you know when therapy is not working? And this really highlights when patients have issues with adherence and compliance. It talks about efficacy signposts, looks at over-treatment and under-treatment. So Sharon and I, Dr. G also are writing, we wrote a manuscript on Wilson's disease, where we talk about linkage of care, talk about barriers to treatment, and how to improve patient outcomes. And in this paper, there's also a patient advocate, patient with Wilson's disease. And what they highlight is with over 100 years of having the disease identified and 4 available treatments, patient in 2025 should not be falling through the cracks, and unfortunately, they still do. So some major unmet needs is, Dr. Gonzalez mentioned very nicely, is we need better strategies to improve diagnosis of Wilson's disease. One of the challenges we face is, like he mentioned, there's no gold standard, and it's usually a constellation of laboratory blood tests, of urine tests, of genetic testing, and histology to make a diagnosis. We need something a little more straightforward. We need safe, effective, convenient, and accessible treatment strategies. And I'll touch upon this very shortly. We need to address patient adherence and compliance challenges. I was telling my partner, Dr. Shetty over here, I finished texting, that we have a patient that is a department CFO at UCLA. I mean, really high level. And this guy, sees me once a year, once every 2 years. Adherence is a problem. And you think about it. Has anyone here done a 24-hour urine collection for urine? Bishoy? You did one? You did one? All right. So, could you imagine doing a 24-hour urine collection at work? Where are you gonna put the urine? In the refrigerator in the staff room? It's very archaic. We need to go beyond the Renaissance. And that's why patients are not adherent. So the tools we have are really outdated. And we need to make sure that we understand individual patient needs and build rapport. So patients with Wilsondisease experience say that they're inaccurate or late diagnosis, and often the diagnosis is brushed off. There's one study that says that over 2/3 of individuals with Wilsondisease were misdiagnosed. With fatty liver disease, with enlarged spleen, and it didn't follow up. Think about it. We were all trained that Wilsondisease occurs in young individuals, young adults, but not people in the 30s, 40s, and 50s. And a misdiagnosis is very common. We've seen patients who were seeing their primary care doctor and misdiagnosed with a stuttering problem, or tremors, or seizure disorder. So it does take a level of suspicion to make a diagnosis. This is from the paper that we're working on, is you gotta suspect Wilsondisease and demonstrate a high level of suspicion and screen for patients. In any patient that presents with neurological symptoms, movement disorders, or abnormal liver tests, but that could be challenged. Check ceruloplasmin. It's an easy test, readily available, and it may be part of the best screening test we have. Refer to specialists. We're lucky at UCLA that we actually have a neurologist, a movement disorder neurologist that focuses on Wilson's disease, and we collaborate quite a bit on studies. And in Wilson's disease, association can help locate a specialist and a center of excellence. And we have to work with their peers as well. We have a number of challenges. Treatment with zinc. Treatment is usually reserved for people for maintenance therapy, but now there's increased enthusiasm that maybe we should be looking at people who are asymptomatic. And how do we identify these? Generally, they're identified because of family screening. You have an index case, an index patient, and then we screen their family members. This is an autosomal recessive gene. Copper absorption with zinc is slower than chelation. So, in people who have active disease, symptomatic, we use a chelator. People asymptomatic, or we might use a zinc therapy. Available in prescription over the counter. The problem with over the counter is, people never get the right amount of zinc that's required. We need 150 milligrams of elemental zinc. And so you have to really pay attention to that bottle you buy from Trader Joe's or the market to make sure. People do have some GI upset, some dyspepsia, gastritis, etc. Chelator agents. This increases free copper, but if you're a little too greedy in the beginning, too aggressive, it may actually exacerbate, and it's an issue, neurological problems. And so you have to be careful. And the people have had this problem for many years. We want to make sure we go at the proper pace. They're recommended doses, trientine and D-penicillamine. Trientine is given as 2 to 3 divided doses and increase over a short period of time. And D-penicillamine is given 2 to 4 divided doses. Both are effective copper chelators. Some patients may experience at least intolerance to D-penicillamine. Sharon and I have one patient D-penicillamine that we inherit from someone else, but our go-to drug has always been trientine because we think it's better tolerated. D-penicillamine can cause skin and kidney manifestation, wound healing issues, and bone marrow suppression. Trientine is original formulation, trientine hydrochloride. It must be refrigerated. So this prevents some barriers to our patient. We had a patient that flew overseas to India, and there are two brothers, and so all during the plane, 18 hours, they had to keep asking for ice because they had to keep trientine, at cold temperatures. Otherwise, it loses potency. So for people who travel, people who go to work, anyone, it's difficult to keep any medication refrigerated for an extended period of time. So that's a very big negative problem. Fortunately, there is a new formulation that does not need to be refrigerated, and is twice dosing a day and can be stored at room temperature. So this provides patients a sense of freedom, from having to refrigerate medication, because it is a challenge. It's a challenge. There's a list of suppliers of this medication, and there's a number of support systems to help people with co-payments and get medication, and also a lot of education for individuals who need to have this new trientine. Compliance is a major issue. Patients just don't come to clinic, and for some aspects, I don't blame them. It's difficult to do a 24-hour urine collection. So non-compliance for Wilsondisease is also very different. If you have someone who's got conditions like diabetes, depression, a missed dose could result in return of severe symptoms. Blood pressure may go up, depression may take a turn for the worse. But in Wilsondisease, a lot of compliance may not translate to immediate symptom recurrence. So people get a false sense of security when they miss their medication. And clinical experience has demonstrated that patient experience is more likely with more convenient and medication regimens. So perhaps this new trientine that does not have to be refrigerated can help with compliance as well. Some tips. This is not just true for Wilsondisease; it's true for most chronic conditions. But recommend having visual medication reminders. Don't store your medications in a cabinet, in a drawer. Have it maybe in a bathroom next to the sink, so you wake up in the morning, you see a medication in front of you. Do have some visual cues. Have the medication off next to you, maybe next to the toothbrush. And studies have shown that their auditory medication reminders do a better job, and to make sure that we take our medication. Again, this is true of any kind of chronic medication. 24-hour urine collection. This is very, very difficult. And this is yet the gold standard how we follow patients in clinical practice on zinc, trientine penicillamine. But it's a challenge to do this every 6 to 12 months. Especially if you're young, if you go to work, if you travel, it's very, very difficult. So some tips, do it on a day that you're not going to be traveling, maybe on a Sunday you're at home relaxing, collect every urine, and make sure it's refrigerated. If this is done correctly, it doesn't need to be repeated. Adherence and compliance challenge with medication lab tests, can lead to patient loss of follow-up, and something we struggle with these every day. Improvement requires, clinician heightened awareness, keeping people motivated, understanding patient individual needs, their work schedules, their travel, and make sure you use as many effective strategies as possible. Build a rapport with patient, and just make sure they understand the seriousness of Wilsondisease. A lot of times, some of these neurological problems are not reversible. So we want to mitigate that. We want to prevent that Wilsondisease from progressing, from taking a turn for the worse. So strategies to build patient rapport and help compliance and adherence, more frequent visits, particularly for newer patients. We've been utilizing telemedicine since COVID. That helps with convenience. People don't have to come to the office, pay for parking, wait in the lobby for 20, 30 minutes, take a day off work, make the patient as comfortable and accessible as possible. Choose medication that best aligns with patient lifestyle. And again, we have this new trientine now that doesn't need to be refrigerated, so it helps patient comply. Commend patient for dosing as advised and encourage follow-up appointments. Other things, I mentioned reinforce the consequences of uncontrolled disease. So in 2025, Wilsondisease, it can be really well controlled. People can live long lives. before we had such good therapies, and share these success stories and get patients motivated and be part of the Wilsondisease Association, which is very, very strong. So now I want to talk about a case that was very humbling for me. And I'll be honest, I did not diagnose this patient. In fact, when the patient was referred to me from one of my colleagues' community, Dr. Reuter, I didn't believe him. He said, listen, Sammy, I got this woman who's 39 years old. And she came into her doctor with fatigue and had some joint aches. And her doctor noted that on a routine blood test that she had a low platelet count. Sent it to hematology. And there was no history that was elicited about jaundice, ascites, no chronic liver disease manifestations, no family history of liver disease. And then the hematologist saw the patient for thrombocytopenia, and got some more history, reflux disease, non-smoker, doesn't drink, works at, was a nurse, no family history of liver disease, took some medications. And the hematologist examined the patient. And the only thing the hematologist found was an enlarged spleen. An enlarged spleen. So the hematologist did some more blood tests, and the liver tests were 100% normal. But didn't notice the platelet count was 78. Then ultrasound, huge liver, huge spleen, and fatty liver. Sent it to my colleague in downtown Los Angeles, and he did a fiber scan, transnasosography, and found to have cirrhosis. Now, how old was she again? Young lady, right? Thank you, I'm glad you're paying attention. 39 years old. 39, cirrhosis. Doesn't drink, doesn't smoke, no drugs. And my colleague orders a ceruloplasmin, 3.78, which is very low. He calls me, Sammy, I got this patient Wilson. Are you kidding? She's 39 years old. The liver tests are normal. I'm going to do a PET test. PET test is normal. And we did a CT scan, splenomegaly. We did an MRI. We couldn't believe the fiber scan. We couldn't believe it. Nodular liver. We did a 25 urine collection. Over 100 mics for 25 hours. We still didn't believe it. How could a 39-year-old woman have cirrhosis? Asymptomatic, impossible. We did a biopsy. Cirrhosis. High copper levels. In parallel, we did the gene test. And she had 2 abnormal alleles. So what'd you do? So compensated cirrhosis, clinical hypertension, treatment naive, and now she wants to get pregnant. What do you guys do? Put on trientine, 50 BID, and 4 years, and we were being following her for a number of years, and little by little, her urine copper been going down. She's feeling a little better, fatigue's improved. Eventually had a baby. And did really well. And I saw her 2 weeks ago, after 4 years diagnosis, and urine copper is 47.2. What do we do at this point? And we did some blood tests. Of course we do blood tests. Liver tests are normal, Billy is great, leukopenia. So should we give her more trientine? Do we need to excrete more copper out of the system? What was that? Back up. She's overtreated. She's got leukopenia and developed a little anemia. She's overtreated. So we cut down her medication. And now the challenge for us is we keep her on trientine once a day or switch over to zinc. But she's doing really well, really well. So Wilson's disease, as you heard from my esteemed colleague, causes both hepatic and extrahepatic complications. And I would argue that when adolescents, let me know if I'm wrong, adolescents come to the clinic with Wilson's diagnosis, they usually have neurological problems. They're caught at school or stuttering or having seizures or tremors. They can't write their name. And the diagnosis, my colleague mentioned, is complicated. We don't have a gold standard. We rely on constellation. urine tests, blood tests, histologic, genetic tests. And we have several really good treatment options. The matter is that the biggest barrier to treating Wilson is not the medications, it's identifying who has Wilson. And then we need to link the person to care and help with adherence for this lifelong therapy that has many, many challenges. So at this point, this is his slide. Is that you? That's you? Wow, it's an awesome picture.
That's my first job.
No kidding. Renaissance man. So, gracias. Thank you for coming to this symposia. And I guess we have some time for questions about Wilson disease from both a pediatric and an adult perspective. Yeah. Yes. Okay. Okay. It's like an AA meeting. Yeah. It's okay, but sure, I could order on you. But it's very difficult. Now, I have a question for my colleague. There's the European guidelines recommend stopping chelating agents for 2-3 days. That's not recommended by American guidelines. What do you do in your practice?
I don't.
You don't. You just keep on trying. We do the exact same thing. Yeah.
It's much easier to do it.
Yes. Yeah. Good. Yes. So the question was, the comment was, in the European guidelines for Wilson, they recommend stopping trientine or penicillin for a couple of days before doing the urine collection. But the American guidelines do not do that. And I asked my colleague in his practice, is he stopping it? And he said he does not stop it. We're not either. Question in the back? Yes, sir. So our patient, we just got this result recently. We're going to probably switch it to zinc as maintenance. But they're already decopperized. And we're lucky here to have another infamous hepatologist, Dr. Jacobson.
Can you hear me? Okay.
Yes.
You can't shout that loud anymore. Your colleague made a passing comment about heterozygotes.
Yes.
I've identified a few of those. They have mild or moderately lower ceruloplasmins, always above 12. And can I assume that their elevated liver tests are not due to the heterozygous state, and that it has to be something else? Or can Wilson's disease do that? I mean, could heterozygosity do that?
Mm-hmm. So one heterozygous, the other one is
it's a few heterozygous patients I've had. I ordered the Wilson's genetic test because they had ceruloplasmins of 12 to 14.
It's a tough one, as I might imagine coming from you, Dr. Jacobson.
Thank you.
I would fall back on perhaps the Leipzig score and ask what that was. Classically, you expect two, it's an autosomal recessive disease, so you expect two abnormals to confirm the diagnosis. But, who's to say that you may have a mutation that hasn't been described yet? As I said, there's over 700 of them. I would make sure that there's nothing else going on, but I would doubt very much that the abnormal liver tests are related to Wilson disease.
Okay, it sort of reminds me of the alpha-1 antitrypsin heterozygous.
Correct.
So I think can get elevated liver enzymes from.
You could have more than one disease.
Yeah. Yep. Okay, thank you.
Sure.
Nice.
Along those same line, actually, I have a patient with 2 mutations that are reported to be a variant of unknown significance. Of course, I did the genetic analysis because ceruloplasmin was low. So now, and the patient has elevated liver enzyme. So now by the Leipzig score, having 2 mutations give you 4 points.
You're done.
So it's done.
Yep.
Even though the 24-hour urine collection is normal.
How old are these patients?
11.
So in children, their copper load may not be as high, and so 24-hour urine copper levels may not be as reliable. If you have 2 abnormal mutations that are pathogenic, they have Wilson disease.
Yeah, it's a variant of unknown significance, but nobody knows for how long it's going to be of unknown.
Correct.
So this is the problem. Now, you would do the biopsy. The biopsy may not be confirmatory, as you know, because they're still young enough, they might not have enough copper. So you are kind of committed to follow them, long-term wise.
Correct, but I think if you have 2 abnormal mutations, I would say you have Wilson disease, period, end of discussion. Regardless of what the 24-hour urine copper might be, or even the liver copper might be, you expect them to be on the high side. But you may not see copper levels In the liver, for example, above 250 micrograms, there may be something less. So I would go back. Again, I'm making a big plug for this Leipzig thing. I would go back. I mean, if you have two abnormal mutations, you have it. There's no answer for bloods, in my mind.
Yeah, yeah. Yeah. I agree, it's kind of a hard thing.
Well, it depends on so once you confirm the diagnosis, then you have to figure out, as Dr. Shulsky taught that this morning and highlighted, you have to figure out where they are in the spectrum in terms of disease, if they're asymptomatic or symptomatic, or how symptomatic are they before you decide what treatment you would start. So it all depends. If you have someone who's got a normal liver numbers, completely normal liver numbers, asymptomatic, and you have Wilson disease, sure, zinc is one of the things that can be used, sure. Chelators can also be used. Yeah, you can.
I think, yeah, I'm having a low threshold of starting treatment. I'm sending them to genetic to do the parent to make sure that this is it like those two mutations on the same gene or on two different?
Correct.
Just in case, not to commit this patient to lifelong therapy, but I agree, it's so challenging when it's.
How low was this ceruloplasmin?
It's in the 12 range, 12, 15, yeah.
Yeah.
First question is, have you noticed that the amount of copper in the liver correlates with the severity of the disease? Because I feel like Wilson's comes in different flavors. So do those with decompensated Wilson who require liver transplant have a higher copper?
Not necessarily at all. Remember, people with cirrhosis may have false normal-ish 24-hour liver copper because of the variable distribution of copper within the liver sample, within the liver. As I've said, copper tends to accumulate in the cirrhotic nodules or the regenerating nodules. So if you have cirrhosis, the amount of copper may not be as high. So there is no direct correlation between amount of copper in the liver and liver disease.
Thanks.
Well, I think this concludes our symposium. Thank you for, oh, sorry, oh, bigger party, sorry.
One last one.
Yes, please.
I'll cut your break, Amal.
So my question in the morning to Dr. Chelsky and the panel was, they presented this cirrhotic patient, and I asked, would you stop chelation therapy? And they said, no, we don't stop chelation therapy. But you were presenting a similar case. She had cirrhosis at the time, and now you're considering stopping chelation because she had a low copper excretion, or you're over-treating. Is that right?
Yes, I overtreated her. And I'm causing now problems with her bone marrow, with leukopenia, with anemia. So we're going to probably switch her to zinc.
Yeah, so you still can do that. I got an absolute no in the morning, so.
I'm not sure that it was that. My take on the morning session was that the comment was stopping therapy would be incorrect. Using something else would be okay.
Yeah.
So when you use the word stop, that's a hard word. So you transition or you use something else.
Yeah.
And you can if you have someone who's stable. Copper white stable, yes.
Thank you. That answered my question.
Well, thank everybody for joining us today. Thank my colleague and my long-lost cousin. And thank you for the questions. And we'll see you outside at the reception. Thank you, everybody.